First of all, thank you very much to the Governor's Institute. I'm new to North Carolina, been here less than a year, and thanks to their leading me, I've met a lot of you. I appreciate being able to speak today and mostly appreciate following Dr. Gonzalez. We have known each other for about 25 years, and every time I hear this lecture on stigma, I learn a little bit more. So this is me, and um, mm, mm, you know, me and slides. There we go. I am, as Jeremy said, a member of the Addiction Medicine Subboard. What does that mean? I certify physicians to take our exam, and I also author questions for the exam. This is the examination that doctors take to be board certified in addiction medicine. I am thankfully retired, and so it's really quite lovely that I just work with the Governor's Institute. Improved understanding of the neurobiology of adolescence and the addiction vulnerability has the potential to refine screening, enhance prevention and intervention strategies, and inform public policy. And I particularly appreciate the comment that Dr. Gonzalez made about how children end up in this vast system and get labeled, and kind of what a mess it ends up being for a lot of youngsters. So I have some learning objectives here. We're going to talk about substance use disorders as a spectrum of chronic disease in adults. Overview in kind of a fun way, the neuroanatomy of reward, including how the adolescent is a bit different. Recognize signs of mis or abuse, use or abuse of controlled substance by screening and talking. Unfortunately, outline the trend of fatal overdoses among adolescents and emerging adults. And then briefly, because I've been asked so many times about treating teens, I realize there's not a lot of clinicians maybe in this audience, but talk about what the adolescent treatment literature says about using medication. So a substance use disorder, this is the new DSM-5 definition. I still call it addiction. Remember, this is developed in regard to adults. Addiction is a disease with a chronic relapsing course for which the cause is unknown and there is no cure, and it can progress to being fatal. This is like asthma, hypertension, diabetes, and cancer. We've had lots of research. We know lots about it, but really don't know the cause. And it comes and it goes. And if you have diabetes, you can't force your pancreas to make insulin. And if you're hypertensive, there's a lot of things you can do, but bottom line, you can't make those numbers change by thinking about it. And what I like about the medicalization of addiction is that it forces me to think about this in the same ways I think about other chronic diseases, which are relapsing. A diabetic doesn't follow their diet, their blood sugar goes up, hemoglobin A1C, etc. There are many, many long definitions, but think about addiction as a lack of control of use of a psychoactive substance, a compulsion to use it without regard to consequences. And if you want more of the definition of substance use disorders and addiction, there is the DSM-5 in whatever rendition we're on this week. It used to be said this was a moral weakness. In 1898, the American Medical Association said, oh, throw all those miscreant alcoholics in prison. Well, they changed their mind in 1958, but it sort of hasn't gotten through to a lot of people. And people with substance use disorders do not need to hit bottom. Their life does not need to fall apart. We need to acknowledge what's salient for that person and what their values are, and work with them around motivating them around their values. So individuals choose to use a psychoactive substance. My children are older, but as teenagers, they would argue with me all the time about this. So if you think about a lever, you're using something, it's making you feel good, right? But you're going back down to baseline. But let's talk about progression to a disorder where you have made changes in your brain cells, your body physiology, and the balance in the neurologic system in the body. Our bodies are so able and capable of balancing. And if you get that out of balance, we want to go back to homeostasis, but it's hard when there's a substance in the middle of it. So using for effect or euphoria or relief, notice I don't use the word high, which is stigmatizing, to use to feel normal. If you are using tobacco, you smoke a cigarette or vape, that effect lasts for about 20 minutes. And then you're in withdrawal and you want your next cigarette because you don't feel normal. Because if you've moved to a level where the psychoactive substance has changed your brain, you are constantly, unless you've got that cigarette in your hand, in withdrawal. So why does this happen? Because as George Koob and Dr. Lamoille so carefully outlined, we recruit when we get into severe disease state, we recruit the fight or flight response. And stress intensifies withdrawal. And so you end up with someone who is in withdrawal and is in such a heightened state of anxiety and panic and discomfort. The only relief is using. And so that's why it's really, really important to think about the use of medication. Use of medication when someone is in withdrawal, and the use of medication as it takes about 6 months for your physiologic state to get back to normal. Okay, I'm going to now talk about the neurobiology of addiction. I am a pediatrician, just like Lucian. That's my mothership. And I love explaining things in ways that are pleasant for people and are easy to understand. And my patients were the ones that brought me to explaining neurobiology this way. Here's the brain. If you cut right through the middle, you got the cerebrum, you got the midbrain with the hypothalamus, and you got the cerebellum, which helps with balance, and it's all balancing on the brainstem. And then you got the pituitary gland, and there it's the master gland. And we could talk about it like that, but I felt like it was meatballs in a bowl of spaghetti when I was a student, when I had to learn it all. Let's talk about the neurobiology of addiction in terms of the ice cream cone being the bones around your spinal cord and the scoops of ice cream representing sections of the brain. So we're going to go from primitive to advanced, and each ice cream scoop we put on this cone as we go up is going to represent part of the brain that's involved in addiction. So remember, I talked about fight or flight, and I don't have problems with a substance, and I use it once and I feel relaxed. But if I continue to use it, I'm going to affect this lower scoop of ice cream, the hypothalamus, my smart coordinating control center, which helps me maintain homeostasis, remember? And it acts via something called the autonomic nervous system and hormones. We ain't got control over our hormones, and we ain't got control over our autonomic nervous system. Although, if you meditate, you can bring yourself to a calmer state. And also in this lower ice cream primitive scoop is the amygdala. And this is where you have an emotion and then it heads up and is linked to other brain areas. Stores primitive memories. I can walk into a room and smell something and it reminds me of another experience in my life. When I was a medical student, I was pregnant and I was very nauseous, and I was working on a floor at Walter Reed Hospital where I swear to heavens, I could smell that cleaning solution and vomit on command. That's a primitive memory that I have stored in this part of my brain. We talked about how getting into the fight or flight with chronic use is an important driver for continued use. And obviously, you have no control over this part of your brain. Then we move to the midbrain, which is, I used to call for my patients, this is your reptile brain. It's your pleasure center. It's where you say, go, 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 go. I want more. And it's hijacked by substances. That, again, is something that was taught to me by the founders of this field, to the point where you move to addiction or substance use disorder. This is the primary reward system in the brain. Every being has to procreate. Every being has to have food and water. And it's darn important that we have a pleasure center that's rewarded by sex and food and water. But this is where the signal of euphoria originates in everything in our lives. And it's projected via some important fibers up to a higher level. And this, if you've heard about the nucleus accumbens and the ventral tegmental area and the midbrain and the cingulate brain, this is all what this is. And it's loaded with messenger substances like dopamine, endorphins, endocannabinoids. And that's how it works. One of my patients said, you can't teach a reptile how to walk on a leash. Precisely. You do not have control of this area of your brain. However, what you got is the frontal lobe, which I used to call the gorilla brain. My original training was in anthropology, physical anthropology, working with primates. And I call this the gorilla brain because primates have a frontal lobe. This causes you to stop and think about it. Primary executive function, this is the last scoop on the ice cream cone. It receives and integrates information. It carries out the essential duties of memory, thinking, learning, reasoning, problem solving, emotions, consciousness, and sensory functions. Or as I used to say, when I had a checkbook, this is where I balance my checkbook. So if a student starts cutting their German class because they have too much to drink the night before and they don't feel like getting up, in some cases, the student will say, oh, wait a minute, I really need to pass this class, blah, blah, blah. But in other cases, if the reptile brain has been hijacked and this person has moved into a state where they're in a cycle of withdrawal and use, they may not stop and think about it. So I'd say to my patients, when you are actively involved in your addiction, your gorilla brain is huge. It's in charge. It's where cravings and cues and triggers, along with that lower brain scoop. And what you need to do, and your gorilla brain is this big, and you need to expand your gorilla brain to tell your to be in charge over the lizard brain. I hope you don't find this too silly. It's something that I even when I'm talking with physicians, I talk about. And on the right, you have the little fellow with his anatomy of the human brain. And I want to remind you that development in a child progresses from being born and being able to just follow with your eyes to get to the breast and see the mother's face to a fully functioning adult. We say it progresses caudate to cephalad, which is a family easy way of saying from your tail to your head. And so the back of the brain, the primitive parts of the brain, are first developing, and the whole brain is not completely formed and developed until you're 24, which is pretty terrifying when you look at the fact that the highest amount of use of many of our substances is in folks under age 24. Moving on, what about teenagers? What about kids and neurodevelopment? Well, there's a prominence of the social emotional network for teens. It's a focused time when there's intense development of dopamine pathways, endorphin pathways, endocannabinoid pathways, and redistribution of dopamine. And I really should list those other things to areas of reward, the midbrain, the lizard brain. And the changes in the system of reward and feedback peak in the teen years. So a relatively small release of dopamine, it's overpowering for a kid, and risk-taking is more rewarding. So you want to teach somebody how to race on a ski hill, get them when they're young. And when they're teenagers, they'll do anything to win that race. Remember that peers can be influences for maybe not some great choices, but they also can be motivations for pro-social behavior. And I say at this point, it's really important there be good communication with family and parents and caregivers, which is protective because there's too much go, go, go in the young brain and not enough stop. This is also the point where I remind people, if you want to do prevention work with families, you need to start when kids are 10, 11, 12. Because if you teach good communication at that point, there's lots of research, understanding what Dr. G said about research and statistical significance. We know that the effects of teaching good communication in families, with families and their youngsters, lasts for many, many years and is protective. So I did a review when I first started giving this lecture many months ago about what works for adolescents in treatment. And this is just one of the many articles I looked at, and my citations are extensive. So what works in adults doesn't work in kids. They're not worried about paying a mortgage and keeping a roof over their head. And very few youth receive treatment, and many return to use when they are using substances in a manner which is not consistent with moving through adolescence. Lucian has really taught me about how the adult criteria for addiction really don't apply to our youth. There's scant evidence of what works in teens. We know that only 20% of adults with alcohol use disorder get treatment, only 10% of adults with another substance disorder, specifically illicit, and very few teens receive treatment that is evidence-based. And many times you get a kid who's in a program where they say, well, we'll just give this kid an adult program and use the same thing. What works in adults is not effective in young. And motivational interviewing may be less robust with teens because remember, they're deciding what's salient and they're establishing their values. The neurodevelopmental changes I just told you about render teens more vulnerable, the huge bursts of reward from risky behavior. And teens have different socioeconomic concerns and foci than adults. They're not worried about a mortgage, but they sure are worried about friends and getting on with them and being reinforced with them. And they often have different trajectories and different goals in treatment. So if I am working with a kid, and I have my first encounter with them, and they stay in my program for a little bit, and then they bolt and they're gone. When they come back, instead of saying, "I can't believe you," I'm going to say, "I am so glad to see you. I was worried and concerned. Can we sort of talk about what led you to going back out?" And again, I'll work with a teen who's still using cannabis. It's not going to kill them if they stop using opioids. And so I have to figure out, as Dr. Gonzalez said, what is the perspective of this teen? What is their life experience? It's really important. A little bit more about brain development. On the left side, you have the brain system and the aging pattern and how it's relevant to treatment. So puberty is a multi-system change that begins at 8 to 10 in girls, 10 to 12 in boys, and with time matures, and you have to identify pro-social sources of novelty to replace substances. Because for this child who's having a problem and has gotten involved with substance to such an extent that it's affecting their functioning in their school and their family and their community, people like feeling good. There are cognitive changes which show fairly linear development from age 10 to age 20. Use those cognitive strategies. Recognize that their cognitive strategies are context dependent. And then the sense of self, we all know the self-awareness of the young teen goes up dramatically. And the self-focus on me, which starts and goes up in early adolescence, comes a little bit down by the time adolescence is over. Kids want autonomy. They have introspection, and we need to look at their role, their life experience, and harness their desire for autonomy. They want to be out there. What do we need them to do to be out there and be safe? And finally, the social landscape. Already talked about pro-social sources of reward, positive peer influences, but don't forget that parents or caregivers or whoever is the adult in this young person's life still have a role, and we shouldn't cut them off. So one of my questions I write is, a team will do better if the family's not involved. Wrong. We have to involve the family. Talk more about that a little bit later. So I'm going to shift here and talk about what substances adolescents are using. I can tell you there are 3 sources of good information about epidemiology. One is the National Survey on Drug Use and Health, which is out of the Substance Abuse and Mental Health Services Administration. I know we've got some folks on this call that are quite connected with SAMHSA. This is a yearly survey of people age 12 and older, balanced for population, excludes people in institutional settings, and looks at lots and lots of things. And all you have to do is put NISDA in your browser and you'll see what a rich source of epidemiology. Also Monitoring the Future, run by University of Michigan, and also NIDA, which looks at 8th, 10th, and 12-year-olds, began in the 70s, late 70s, with 12th graders added on 8th and 10th graders, and now follows people up to age 60. And it's about a lot about substance use. The Youth Risk Behavioral Surveillance System, which is run by the CDC, I'm going to talk more about, but is a yearly study that's done in schools with kids beginning in middle school. So this is from the National Survey on Drug Use and Health in 2022. And I put the slides up because if you look at the gray is, okay, on the y-axis, percent of past year initiates. On the x-axis, different things: cigarettes, nicotine, vaping, alcohol, and marijuana, or cannabis, I prefer to call it. And the gray is first used at age 21 or older, which frankly is still adolescence, but late adolescence, and first used before age 21. This is what kids use. I know we're very focused on the opioids right now. They use cigarettes, they vape, they use alcohol, and they use cannabis. In 2022, initiation of use, almost three quarters cigarettes and alcohol. So that's sort of what I'm going to talk about for a bit in the epidemiology of use. So this is again from NISDA, past months tobacco product use or nicotine vaping among people aged 12 or older. And I'm sorry that this lags a little bit in time. So here you go. We've got about 63 million people, or a little less than 23% of the population using tobacco products. 23.5 million are vaping, and I'll tell you that's gone up to 25 million in the next NIST the 2023. But let's look a little bit more closely and see the type of tobacco use among past month, not initiates, 12 or older. Again, percent using in the past month on the y-axis, on the x-axis, you see 12 or older, that's everybody. 12 to 17, they're vaping. 18 to 25, yes, they're vaping more than using these other tobacco products. 26 or older, pretty much using other tobacco products. Here's an important point. Some new information came out. Kids are not only putting nicotine products in their electronic delivery devices or vapes, they are using cannabis products and getting into quite a bit of trouble since in the 70s and 80s, the cannabis products were about 15% THC now, which is the psychoactive ingredient in cannabis. Now we're up to 90% concentration in something called wax or dabs. So I put this slide up to remind you that there are racial and ethnic differences in substance use, and they would surprise you. Compared to what the media is telling everyone and what you're hearing, I know, for instance, among 12 to 20-year-olds in nicotine use, about 16% of folks who are white are using, this is age 12 to 20, even though this says in the title 12 or older. Age 12 to 20, about 16% of white youngsters are using nicotine in vaping form usually. About 11% of folks who identify as Hispanic, 10% of kids who identify as Black, and 5.6% of kids who identify as Asian. So that's important to think about in the stigmatizing of who's using vaping and using tobacco. In regards to alcohol, youngsters 12 to 20 who are white surpass all other racial groups in the past month that they have binged, used, or heavily used alcohol. So if you're interested in different groups of folks, I don't like the word race, it's a social construct. There is information, again, through SAMHSA on different racial groups. Let's talk a little bit about YRBSS. A set of surveys, they track kids about behaviors that can lead to bad health from grades 9 to 12. They're every other year. I think I said every year originally. And they look at things like student demographics, youth behaviors and conditions, not only substance, but sexual injury and violence, bullying, substance use behaviors, vaping, tobacco product use, alcohol use, and student experiences around parental monitoring, school connectedness, unstable housing, exposure to community violence, and there's data information that is gathered on the ever-changing climate of gender identification, sexual orientation, and there's no identified data collected. So what I like about the YRBSS is you can go down to the state level, so it's really great. So in North Carolina, this is beginning in 1993 all the way to 21, high school students who ever used marijuana, ever. And it's was about 29% in North Carolina beginning in the early 90s, and we're still at about 29%. We had a little uptick and now we're going down again. But let's compare it to the United States. And this is what's really great. So the triangles are the US, and the red line, as we saw before, is in North Carolina. And you can see that, our high school students are using a little bit more than across the nation. So I will go back and show you high school students who ever used cannabis. And you can easily get this, go into YRBSS. There's a drop down where you can pick your state and you can pick your substance. And then the same thing nationally. And in North Carolina, showing that there's been a decrease nationally, but we're sort of about the same. This is an important slide, and I hope it's easy to understand. Almost 16% of North Carolina high school students reported misusing prescription drugs in 2021. This is things like Vicodin, oxycodone, benzodiazepines like Xanax and Valium. And this misuse, identified a long time ago, is using without a prescription, someone else's, whether you are sharing or you stole it, using in a manner other than prescribed. So if you're told to take it every 8 hours and you're taking it every 4, if you're told to take it orally and you're insufflating into your nose, and that's almost 16% of our kids. And then the currently used alcohol is the last month. Ever used marijuana again is ever. Wow, somebody advanced me, not me. 0.8% using heroin and 1% using methamphetamine. I want to tell you that it used to be that I could say one pill won't kill you. Unfortunately, in the current climate, with illicitly manufactured fentanyl drugs with press pills, where it's labeled oxycodone and a kid takes it, but it's fentanyl and it's got fentanyl and they've never had an opioid before, one pill can kill. And that's why, and I will talk with you a little bit more, we should be talking to kids about this. We should be getting naloxone distributed. Every family should have naloxone, and every family should know how to use it, and every youngster should know how to use it. Interesting study in Alaska, where among Native communities where the overdose rate is very high, they much higher use of naloxone in that area. Okay, I am not going to stop for questions. I'm going to plow on and talk to you about talking with teens about substances. I have, especially when there's a problem, but I really wish that we could all talk to every teen about this. So, universal screening for substance use. This is tough. We're asking pediatricians and family docs and primary care providers to do so much. You've got time constraints. Where are you going to refer a kid? This is what I get asked all the time. But where do I refer that 13-year-old who's had an overdose, a non-fatal overdose and needs treatment? But according to my training and Dr. Gonzalez's training as pediatricians, we do psychosocial histories from early childhood. Do you have a gun in your house? I ask the parents of a newborn. If you do, lock up the ammunition and the gun separately. But really, about around age 11 to 13, depending on the maturity, we should start talking to kids about substances. And this is a confidential discussion you're going to have with the child, but you need to let the parent know. Many times parents don't want to leave the room. I'm fine with that. If the parent will leave the room, I say, you must know that if your child is engaging in something that is risky to them, you will know about it. And I say to the teen, if you tell me something that I feel needs to be shared with your parent, we're going to do it, or your caretaker, and we're going to talk about how we're going to do it. You're going to do it, I'm going to do it, but confidentiality for pediatricians, family docs, and providers working with youth varies by state, but we must never hold information that could harm a child terribly. If you're going to screen, use a validated screening tool, for heaven's sakes. There's a lot of them. I'm going to talk about one, and be non-judgmental and empathetic. So last time we talked, you said you weren't using any alcohol. How many days did you use alcohol since I saw you last? That's not a screening question. That's something that I may have with the child because I've already talked to them about alcohol. I like the S2BI, screening to brief intervention, which has, for those of you who like statistics, a 90 to 100% sensitivity, which means if you have a problem, it's going to be identified, and a 94% specificity. And that is, if you don't have a problem, we're not going to say you got a problem. So, and it is sensitive and specific for each substance that we're talking about. Screening to brief intervention is a gamish of SBIRT, Screening Brief Intervention Referral to Treatment, National Institute of Drug Abuse, National Institute of Alcohol Abuse and Alcoholism, lots of research around the country. It has 2 questions. In the past year, how many times have you used tobacco? In the past year, alcohol, marijuana, or cannabis? Second year, it says they have in the last year. In the past year, how many times have you used prescription drugs that were not prescribed to you, such as pain medications? Adderall is another one that we need to ask kids about. Illegal drugs like cocaine or ecstasy, inhalants such as nitrous oxide, spray paint, and then bath salts, things that are other kind of illicit substances. So if a child says never, never, Dr. Wunsch, and I believe them. It's better to be fooled by 99 people than not believe one. You're done with the first question. You want to give positive reinforcement, permission to talk about this. I'm really glad to hear, Melissa, that you're not using alcohol or tobacco or cannabis. Most kids aren't. And then I'm going to say, but it's got to be medical feedback. You know, kids who use alcohol sometimes end up in risky or scary situations, different to a 12-year-old than a 17-year-old. And I'm going to try to customize the message. I'm so glad you're not using tobacco. It's not good for your asthma. You might need more medications. We worked really hard to make that something that doesn't interfere with your life. So that's for the young person who says, in the past year, I've never used any of these 3 substances. Now, what about if they say, oh, I've used alcohol a couple of times? Or, you know, smoked a joint with my friends a couple of times. In the past year, how many times have you used prescription drugs not prescribed to you, illegal drugs, inhalants, herbs, or synthetic drugs like K2, salvia, bath salts? And if you talk to kids, you'll find out what's being used in your community. They'll tell you they know what's being used. And you ask this question, you move on to it. So what about this kid that's used a couple of times? Where are you going to go with that? Well, this patient is unlikely to meet a criteria for substance use disorder per DSM-5. They're basically, you need to advise to quit. Hopefully, we're in communities where we know our patients, we know our kids, but you have to strongly advise to quit. I would recommend, for the sake of your health, that you not use alcohol or cannabis and tobacco. And then you know this kid, you know what's going on. You've talked to them already. So you want to focus on goals and consequences and tailor that message to that kid. I know staying on your soccer team, especially being the captain, is really important to you. And being a leader ready to work out and be clear-headed using cannabis can interfere with all that. And if they want to say how, I can say, well, you might get more short of breath. Or you might find that you cough more because you got to get that stuff up. I agree with Dr. Gonzalez that cannabis is racialized, as is every other substance. So you got to know what's going on with that kid. And you want to personalize it. You know, you broke your leg last year skiing, you're still on the ski team, you had an injury last year, smoking or vaping nicotine can interfere with healing. We know that. So it's medical, it's not moral. And that's really important. Advise to quit, focus in on. This child does not necessarily need to be referred anywhere, but you sure as heck need to see him again. See if you can see that kid again in a month or 3 months, get them back in. So what about if a teen tells you they're using monthly or weekly? This would make the hair stand up on the back of my neck, because these youngsters are at a higher risk to meet a diagnosis or to be in a lot of trouble with substances, and especially if it's accompanied with a decrease of function in their academic world. I mean, let's face it, the kids who get to school, that's their job. Let's worry even more about the kids who aren't in school. Socially, are they in trouble? Is the family coming to and saying there's trouble? Have they been involved and have a probation officer? What else is going on in their life? Now, a moment about encouraging involvement of family and caretakers and options. So I'm a specialist. If I'm working with a youngster and we've agreed that that person's going to go on some medication, I will say to them, I know you don't not want your mom, your grandma to know what's going on. It's going to be really hard for us to work together and not have an adult in your life involved, an ally. Is there someone you would like involved? You're going to need to get here. You're going to need to pick up prescriptions. I mean, engaging with our medical system is not for the faint-hearted right now. And so I work hard to have my patients involve an adult they trust. Um, at that point, as a non-specialist, you're obviously going to advise to reduce use and risky behaviors. You can use motivational interviewing. We talk about ORs with open questions, affirmations, reflective listening, summarizing. If you have a teen that is using nasally and using orally, ask them if they thought about injecting. And if they thought about injecting, talk to them about using works, using needles that haven't been used by someone else. Talk to them about not using alone. Introduce them to things like a phone line that people can call when they're using, if they're using alone, so someone knows what's going on. And you're going to need to refer this youngster for further assessment. I hope you have someone to refer them to. They need specialized evaluation for co-occurring modalities. They need treatment. And this is a scary situation for someone who's sitting in an FQHC in the middle of nowhere. So networking is really important to know where, and I'm not necessarily talking about referring to a physician or a prescriber. You may have an excellent person by your side in behavioral medicine who can go ahead and take this on. Unfortunately, we need to shift here to youth fatal overdose. My first research now 20 years ago in Southwestern Virginia was with a medical examiner who came to me and said, Marty, the bodies are piling up. This was in Southwestern Virginia. I got adults who are coming in with overdoses. There's no illicit drugs. It's all prescription medications. And we went forth and we identified in 1,000 overdose decedents what they were using and how old they were and who they were. Well, this trend has increased. I hear it's maybe going down a bit, but our youth are getting involved, which in my opinion is terrifying. So I'm going to take you through some literature. This is from MMWR, drug overdose deaths among persons 10 to 19 between 2019 and 2021. The median monthly overdose rates, this is national, increased 109% from July to December in 2019, the same period in 2020. Deaths involving illicitly manufactured fentanyls, IMFs, increased 182%, which is why we think about one pill for a non-tolerant person being so dangerous. And 90% of the deaths involved opioids and 84% involved these IMFs. And heard a lecture from George Koob yesterday, the director of the National Institute of Alcohol Abuse and Alcoholism, that 40% of overdose deaths involve alcohol. Not sure what that number is for kids, but for all comers. About counterfeit pills, those are the pressed pills I talk about where a kid says, oh, this is oxycodone, I got it from my grandmother. But no, indeed, it's a pressed pill, which the grandmother may have gotten, present in a quarter of the deaths. And in 2/3 of the death, there were bystanders. Nobody replied, nobody had naloxone. Nobody knew how to stick it up somebody's nose and squirt it before they called 911. And 41% of the cases, there were evidence of kids with mental health conditions or having had treatment for addiction. For substance use. So if you have a non-fatal overdose in the next 6 months, you're extremely high risk to have another one. So this is North Carolina data. Hurrah that we've got state level data from the Center for Vital Statistics. And we know that our overdose rates here for 25 to 54-year-olds are highest in American Indians, non-Hispanic whites, and those 25 to 54. So you can see males, okay, I'm not touching anything, I promise. Medication and drug overdose death rates per 100,000 North Carolina residents. And you can see it's 40 per 100,000, more males than females in the dark blue. I worked with folks from First Nations in the West I'm not as familiar with what's going on with First Nations or American Indians here in North Carolina, but a very high rate of overdose. And then you see in the purple, the highest rates of overdose are 25 to 34-year-olds. In my work 20 years ago, the average age of the females was 42 and the males was late 30s. And that was what was going on nationally. And now we've cranked down to where our young people are being involved. This is 2017 to 2020. Overdose deaths among 15 to 24-year-olds. All overdose deaths you can see cranking up from 1999 to where we are. Opioid deaths, so where opioids are identified, and I will tell you the medical examiner system of classifying deaths is not perfect. But opioids identified on toxicology, and then cocaine deaths down in the blue and heroin deaths. This is 15 to 24-year-olds. Monthly rate mortality per 1,000 population on the left. The years going up to 21 on the right. Non-Hispanic white in red, monthly trends in drug overdose mortality by ethnicity, youth aged 15 to 34. And blue is our First Nations, green, our Black population, Hispanic, and then on the bottom, Asian. If I haven't convinced you yet, we've got a problem. I'm going to talk a little bit about medication. This is a new addition to this talk because I had a question from a nurse practitioner. You know, Marty, I have a 14-year-old with non-fatal overdose. Should I put this kid on buprenorphine? Well, buprenorphine is only licensed down to age 14. And yet, as a pediatrician, I might think long and hard about the risk of not putting a 13 to 14-year-old on medication for at least 6 months after a non-fatal overdose, in addition to intense work in other areas of that child's life. So I'm going to run through what I found in a literature review in about the last month. 2017, JAMA Pediatrics. Trends in recent buprenorphine and naltrexone for opioid use disorder among adolescents and young adults. This is 2001 when we first started using Suboxone and Subutex. And in this large national retrospective cohort, this is from insurance data of over 20,000 youth, 13 to 25, who are said to have opioid use disorder. We had an increase in medication receipt, but only 1 in 4 individuals received buprenorphine. When I looked at the literature, this is true. Younger folks, females, Black and Hispanic youth were less likely to receive treatment. I found very few instances of youngsters under age 17 in my review. This is from the American Academy of Pediatrics, the mothership for Dr. Gonzalez and I, about medication-assisted treatment of adolescents with opioid use disorders. Whether or not you agree with the diagnosis of an opioid use disorder, we get kids dying and falling out of engagement in our communities from use of opioids. And in 2016, the Academy said, this is a chronic relapsing disorder. Rates of spontaneous recovery are low, and it can be improved if you give a kid medicine. And we advocate for more resources, for access, and we need developmentally appropriate treatment for these youngsters. You can look at the adult literature. Clearly, medications improve treatment. We don't talk about medication-assisted diabetes treatment. We're just talking about medications, for heaven's sakes. We don't talk about medication-assisted any other chronic disease, but that's how we talk about it. So this is a article that talked about, this is from the Journal of Adolescent Health just 3 years ago, recommends all adolescents and young adults with opioid use disorder should be offered medication as a critical component of integrated treatment approaches that includes pharmacologic and non-pharmacologic strategies. I often hear, well, their brains are growing. I don't want to expose them to buprenorphine. I say, well, this youngster's already exposing their brain to oxycodone, fentanyl, heroin. I think we need to think about this as maybe something we need to do. And yet we worry about giving kids medications. And you will hear it's substituting one drug from the other. I don't want my child addicted to another drug. And so we have to work hard to talk about why medication works. This is from Addiction Science and Clinical Practice. This is a little bit terrifying. This is a pediatric emergency department. So these are docs who are board certified in pediatric in emergency medicine. They're pediatricians. And 3 out of 4 say, yep, I'm in a PZR and I manage, 74% of them said I manage substance-related visits. And half of them were not comfortable managing withdrawal. Remember the fight or flight. Remember the lower part of the brain. And 73% of them were not interested in prescribing buprenorphine. These are pediatricians. I'm really glad that we're reaching out more to pediatricians, but frankly, I had no training in this area. And finally, George Woody's study, which is old, it's from 2008. Because people say, okay, I'm gonna stabilize this kid on buprenorphine and then I'm gonna get him off. I don't want too much exposure to this drug. Well, so basically they had a detox group whose mean age was 19. And they had a 12-week group. So the detox group was, you got buprenorphine, you felt better, and then we tapered it off, usually 5 to 7 days of treatment. And the 12-week group, they got buprenorphine and naloxone or Suboxone for 12 weeks. And these groups both had the same other non-pharmacological treatment. And then they were tapered off or detox. I don't like the word detox. It's called medical management of withdrawal. About the same males, about the same age, very few under age 18 in either group, mostly white folks. And here's what they found. This is the worst slide I'm going to show you, I promise. In the post-treatment phase, so you've got the primary outcome is opioid positive urine drug test. Now, urine drug test is like a blood sugar. It's a moment in time. But they had secondary outcomes of dropping out of treatment, self-reporting use, injecting, enrolling in addiction treatment elsewhere, use other drug use, adverse events, and so the top level is the patients who were on for 12 weeks. This open, the closed circles are patients who were detox patients, 5 to 7 days of bupe, have a nice life. And you can see that 20% of the patients in the group that only had a week of buprenorphine completed treatment. In other words, the non-pharmacological, whereas 70% of those in the 12-week group. So this talks to us about, if we get these kids stable, let's keep them on this medicine until their brains are better and they're, doing better in their life and with their family and they're back in some sort of educational setting or for older adolescents work. Again, the x-axis is time and the y-axis is opiate positive urine results. So this is from the Journal of Addiction Medicine. Disclosure, I used to be one of the editors. And this summarizes some trials that were done in 2005, 2008, and 2016 across the nation. And again, you've got, clonidine, detox, bupe detox. You've got 2 weeks of buprenorphine, 8 weeks, and then a 4-week taper. You've got 28-day detox, 56 detox. And again, these are not young folks. The point of the slide is to say, I couldn't really find anything on the 14 to 18-year-olds. So that is the end of my presentation, and I think I've given 6 minutes. The last few slides are, if you have a family and you have a kid that's interested, I used to pull up the NIDA website, NIDA for Teens. It's great. Kids loved looking at it. And I would say, now I'm a specialist, so I had the time to do this. Here's your brain, here are the cells, here's what's happening. And also, they have for parents starting a conversation about drugs and health. I thank you so much for your attention. I thank the Governor's Institute for inviting me. I am there's 300 people on this. This is so amazing. Let's go out and treat addiction and save lives. And for the policymakers and law enforcement and social workers and everyone else that's here, I am so pleased we're taking a community response. So, questions? Jeremy?
Dr. Wunsch, we're grateful to you for working through so much content so quickly. We appreciate the way that you have prepared yourself with prior research and just all the conversations that you've had across the state to bring this information forward. And we know that you're committed to continuing to be a wonderful consultant for us here at the Governor's Institute and to serve others across the state. I just wanted to respond to a few of the comments that have come in the Q&A. There have been several questions about access barriers and what is the state and what are other folks doing to meet those needs. I wanted to mention in response to that Director Kelly Crosby will be joining us and be touching on several of those things at 11 this morning. But Dr. Wunsch, we did have a specific question come in about treatment and buprenorphine. There's a question that says, I'm unsure of how to determine when to start bup. Is the S2BI enough of a screening tool to start bup, or do we need to use something like COWS to determine when to start? Thanks so much.
That's a great question. So I will tell you there's an 8-hour course that's online that you don't have to do this anymore, but if you're going to prescribe, buprenorphine, naloxone, please take the course. So you're right, S2BI is a screening instrument. Now you got a patient in front of you who screens positive. And giving buprenorphine and naloxone when a clinical opioid withdrawal score is positive will make that patient feel better very, very quickly. And I don't talk to diabetics who have blood sugars of 500, nor do I talk to someone who's inebriated. And someone who's in horrible withdrawal cannot engage with you until we get them physiologically stabilized. It's just like any other medical condition. So yes, you do have to assess that someone is in withdrawal to start buprenorphine, but you also, if you're a prescriber, you can prescribe, but would you hand a diabetic insulin and not have them work with someone else on the non-pharmacological management of their diabetes? And in that regard, you got to get some psychological support. Now, there is a study that came out that said, if you have bup and you don't have counseling, it's just as good as if you just have bup. Well, here's the bottom line. I have never met someone whose life was being destroyed by addiction who couldn't use some kind, empathetic support from a behavioral health provider, which happens to be me as a specialist, but I still engage someone. So look for the 8-hour course. Take it. I have offered to the Governor's Institute. I'm in the process of getting a license of being a consultant in this whole process. I'd love to come out and work with some of your clinics. You don't want to give buprenorphine to someone who's intoxicated and has pinpoint pupils. They'll go into precipitated withdrawal. So I hope that's enough of a answer. I have, what is the name of the website at the end of my, it's NIDA.gov. National Institute of Drug Abuse, NIDA.gov. If you put in just NIH, so the National Institutes of Health, you've got NIDA, you've got NIAAA, NIDA.gov. And thank you, Paula, for putting that in. Any other questions?
We can wrap with one final question, and then if you have time to answer, maybe there's a follow-up question about dosing for a 16-year-old, that would be great as well.
Okay.
But Dr. Stephen Wyatt asked the question, do we have thoughts on the use of naltrexone in adolescents?
Wow. Hello, Steve. Steve and I have known each other since we were 18 and went to college together. Thank you for that question. When I talk about medication for opioid use disorder, there are 3 medications we can use, right? There's buprenorphine, there's methadone, there's naltrexone. I think that's what you're asking me about. And so I would tend to use naltrexone in a youngster that has been stabilized on buprenorphine, is plugged into treatment, and is now saying, I'm going to college, I've done really well, I want to use naltrexone every month. You also have to be very careful initiating naltrexone if someone's been using, but there's really nothing in the literature. And yet we have pregnant women whose fetuses are exposed to naloxone are doing fine. You're not going to, I don't think you're going to hurt the endorphin system in an adolescent.